later on, Synanon kind of became something of a cult. I mean, the founder enriched himself through this program. They made millions and millions of dollars. He would start ordering vasectomies for people in the community, shaved heads, forced marriages.
Families, right?
Exactly. And it kind of went off the rails. But it really showed how this model that requires work can become something exploitative.
Welcome to Forum. I'm Alexis Madrigal. In the mornings walking from BART across the Mission to the station, I often wonder about the lives of the people I pass doing drugs on Cap Street and the alleyways of the neighborhood. Sure, they've made bad choices, they impose costs on everybody else in the city, but how can it be that our region, our state, our country cannot help people? Even after 1 million Americans have died of drug overdoses. The failure is so profound that I think a lot of us have developed some ethical loopholes about people suffering from addiction. They're lost to us, no treatment works, once someone goes down that road, it's too late, et cetera, et cetera. But one thing that Shoshana Walter's book irrefutably shows is that when it comes to addiction treatment, when it comes to helping people who want help, we're just failing people horribly, up and down the socioeconomic ladder, but especially those at the bottom, and even worse, a small number of people are profiting off exploiting the vulnerable. Here to share more about her book, Rehab, an American Scandal, and the reporting that informed it, we're joined by Shoshana Walter, an investigative reporter with the Marshall Project. Welcome.
Thanks so much for having me, Alexis.
So the narrative that I have in my head about drug treatment in this country is that because the opioid epidemic hit a broader swath of American society than crack before it, our country decided to take a gentler, more treatment-based approach to drug addiction. But your book shows that we didn't really do that. What went wrong? What happened?
Yeah, I mean, exactly. Like you said, during the crack cocaine epidemic, our country's approach to treating a drug addiction was to criminalize, to punish, and that led to mass incarceration of drug users, disproportionately Black and brown Americans. Then the opioid epidemic came around. It was more of a pain pill epidemic, mostly affecting white communities. And so there was this major transformation, a well-intended transformation, and a widespread acknowledgement that addiction is a disease. It's a disease that's worthy of medical care and worthy of treatment. And so over the past 25 years, we've seen this enormous expansion of our treatment system. First with the launch of Suboxone, the gold standard addiction treatment med, in 2002. And then with the Affordable Care Act, millions more Americans suddenly had coverage of addiction treatment. But the system is really not working the way it was intended. A lot of these issues, and specifically these issues that I lay out in the book, have to do with people still being punished for their addictions, being sent to treatment programs that send them to unpaid labor jobs working for some of the largest companies in America. We have medication-assisted treatment like Suboxone that's still so hard for patients to access. Many doctors don't want to prescribe it. And then we have insurance-funded treatment, oftentimes these 30-day inpatient programs that people come out of and they relapse. We now know that someone who completes a 30-day treatment program is much more likely to overdose and die in the year after treatment than someone who doesn't finish it at all.
Which is it just goes to show how poorly we're doing this. Like, this is the exact opposite of what one might expect. Like, treatment is supposed to make you better, not worse.
Right, exactly. And I think, even the best intentioned treatment programs, some of them feel really frustrated with this limitation that's often imposed on them by insurance companies. And then some treatment programs have taken advantage of it and view it as part of their business model. There was one treatment company owner I interviewed who, in his treatment program, they were over-medicating patients to the point of impairment and contributing to overdose deaths in their own program. Even he was frustrated by this limitation. He called it a cycler, and his company staffed employees to call people who would leave their 30-day program, find out if they relapsed, and then if they did, especially if they had very good insurance, re-enroll them.
Bring 'em back,
So
yeah.
it was just a cycler going in and out.
We're going to go deeper into all these issues, the Suboxone, different types of rehab centers and why some of them don't seem to work or work in ways that seem cruel and unusual to me. But let's talk about how you got into writing this book. It was like 8 years ago, you started looking into some of these treatment centers, and you found people working as part of their drug treatment for some reason in like a chicken processing facility. Tell us more about that.
Yeah, I was a reporter at Reveal from the Center for Investigative Reporting at the time, and I just kind of stumbled across this program that a lot of drug courts and diversion courts in Oklahoma and Arkansas were using. And these were people who were supposed to be receiving addiction treatment instead of incarceration. It sounds great. But when I looked into this rehab program, I discovered that it was founded by former poultry industry executives. And these rehab participants were being sent to work unpaid at chicken processing plants where they were making chicken products for KFC, Popeyes, Walmart, PetSmart, Rachel Ray Nutrish, these products that almost every American consumes. These participants, that was predominantly their sole form of treatment, was just this unpaid labor.
And you trace some of this in the book, and this company arises called Senecor, that one of the main characters in the book goes through at least some of their program. Where did they come from, and where did this idea that putting people to work with kind of minimal actual counseling and other things might do something for them?
Yeah, this Senecor's model was this program called Synanon that was founded in 1958 by a former oil salesman who struggled with alcoholism, and he had tried AA and he hated it because he felt like people relapsed and lied about it in AA, and he didn't want to let himself or other people get away with that. So that was kind of the underlying premise for this new entity.
Like a tougher love was needed.
Exactly. And this kind of became like the precursor to rehab in the United States. It started out as this community where people got together and called each other out on the BS and screamed at each other and confronted each other. And then it grew and grew and grew. And it ended up becoming these recovery communities that existed across the United States, including in the Bay Area, where people lived and worked and held each other accountable via these what was later called attack therapy, also known as the game, these circles of calling each other out. And these program participants would work. They would work unpaid jobs to kind of fund the program. And at the time, this Synanon really gained popularity during the 60s and 70s, and it grew and grew and grew. And it was adopted by a lot of other programs, including the Senecor Foundation. Later on, Synanon kind of became something of a cult. I mean, the founder enriched himself through this program. They made millions and millions of dollars. He would start ordering vasectomies for people in the community, shaved heads, forced marriages.
Families, right?
Exactly. And it kind of went off the rails. But it really showed how this model that requires work can become something exploitative.
I mean, on the face of it, it seems a little crazy. Is it that for some people it did work, though? And so they became kind of like the key advocates for the organization. Like, well, look at me. It worked for me. It could work for you, right?
Yeah, I think so. And I think there's something really compelling narratively about people going into a program and just, completely transforming their lives, one participant, when I was at Reveal, we did a podcast series called American Rehab, and my colleague interviewed some former Synanon participants, one of whom was like, yeah, we brainwashed people, because their brains are dirty. We brainwashed them. I think the problem is, though, that, what ended up happening is people would go into this program and they'd stay sometimes for years, and they would leave and they would relapse. So, and that's a very common theme in different models of treatment that we've tried over the years in the United States. People entering, they're there for a period of time and then they leave and it doesn't work anymore.
Yeah. I mean, is there anything to the idea that once people are really deeply addicted to drugs in particular, there's not that much we can do, or not?
No, I think there's so much we could do to help people recover from addiction. I mean, a lot of people recover from addiction over time, on their own. Some people don't even need treatment. I think people age and grow, and naturally that's what occurs for a lot of people. They actually grow out of it. I think the problem with our drug policies in the United States is that when someone is in their addiction for a long period of time, it increases their level of marginalization, and it becomes harder and harder to find your way out of it, because then you're lacking things that you really need in order to sustain long-term recovery, such as housing, such as job, financial resources, social supports, transportation. The longer you're in your addiction, the harder it is to accumulate these things that are so important. And then there are other barriers to recovery and treatment that exist too, that I detail a lot in my book.
Yeah, you call it recovery capital, right? Or that's a term that is used in the field.
Yeah. I spoke with a lot of researchers who told me about this, about how important this idea of recovery capital is. These are the resources that people can draw from to facilitate change in their life, to even be able to envision change in their lives. And it's, everything that we just described, all the things that you need to really build a new life for yourself. Community, housing, transportation, food, financial security. Without these things, you go into a treatment program, you leave. It's almost like relapse is inevitable.
We're talking about America's drug treatment systems and the rehab and addiction recovery industry. We're joined by Shoshana Walter, author of Rehab, an American Scandal. She's now an investigative reporter for the Marshall Project. I want to hear from you. Have you had experiences with the rehab industry as a patient or as a provider? What was your experience? You can give us a call. The number is 866-733 6786. That's 866-733-6786. You can email us, forum@kqed.org. All the social media things, Blue Sky, Instagram, Discord, or KQED Forum. I'm Alexis Madrigal. We'll be back with more right after the break. Welcome back to Forum. Alexis Madrigal here. We're talking about America's drug treatment system and its failures. We're joined by Shoshana Walter, author of Rehab, an American Scandal, now an investigative reporter for the Marshall Project. One of the kind of probes for the system that you use in this book is the way that the American healthcare system has or has not deployed the drug Suboxone. So first of all, tell us what that drug does, and then tell us about sort of the American regulation around it versus, say, how it has been done in France or other countries.
Yeah. So Suboxone is actually buprenorphine. It's a drug that operates similarly to methadone. It operates similarly, almost, I would say, to nicotine gum, in that it's like a substitute for illicit opioids. And if you take it, and if you're an opioid user and you take it, it quells your cravings. It gets rid of any withdrawal symptoms. It kind of just makes you feel normal. Kind
of hitting the same receptors in your brain, but without the same kind of high.
Exactly. Yes. And during so U.S. drug policy for almost a century did not allow doctors to prescribe narcotics to patients who are known to be addicted. So around 2000, when we were dealing with our own opioid epidemic, lawmakers were really interested, particularly then Senator Joe Biden, were really interested in developing and launching a treatment for opioid addiction that could finally be prescribed by a doctor out of a doctor's office. And so at that time, back in 1995, France had dealt with its own heroin epidemic. where people were dying, particularly of HIV and AIDS. And so their response to this was to release buprenorphine as widely and as widely available as they can make it, with any doctor able to prescribe it, with any pharmacist able to dispense it. And within 4 years, their overdose deaths dropped 79%. It was wildly effective. They didn't have any kind of limits on it. In the United States, instead of releasing buprenorphine to the American addicted public, government officials wanted a special formulation, which would come to be known as Suboxone, that combined buprenorphine and this drug called naloxone, so that if you tried to misuse it and injected it, it would cause immediate withdrawal. So basically, it would deter people from misusing it. We created this brand new medication, and then because it was a brand new medication, the company that developed it, the private pharmaceutical company, received this special status from the FDA called orphan drug status. And that gave it 7 years of exclusivity on the market, a total monopoly on this addiction treatment. No generics would be allowed to enter the market during that time. And when lawmakers finally passed a law allowing Suboxone to be released to patients, there was still a lot of concern among certain government officials, particularly the DEA.
Yeah.
Yes, exactly. About they didn't want a France. They didn't want this drug to be as widely available.
Why is that? Like, what was the concern actually?
I think this is a holdover from that century of drug policy. Where, and also the DEA, they're concerned about drug diversion. This was a little bit before we understood that pain pills were being distributed via these pill mills, and there wasn't as widespread acknowledgement of that going on. But the DEA, I think, was concerned about creating kind of like another drug epidemic, that maybe by releasing this medication as widely as France, they would create another drug problem in the U.S.
Because, like, if me, a non-opioid user, were to take this drug, I would experience it as some kind of high?
Exactly, yes. Like, if someone who is not a drug user takes buprenorphine or Suboxone, it is possible to feel some sort of high from that. It's not as intense as other drugs. Like, what I've heard from so many researchers is if you have your an array of options before you, that's not the one you would necessarily choose. But I think there was this major concern from the DEA that they would create this other drug problem. And I think there's just this still to this day, this stigma against these opioid substitutes or treating drug addiction with a medication. There's this feeling like, if you're going to be sober, you should do it without any assist. You need to pull yourself up by the bootstraps and just do it. And so I think that's still a kind of a stigma against addiction treatment medications that persists.
So what has happened in the time, just like say the last 5 or 10 years? I mean, access to Suboxone has increased, right? At least that's my understanding. It's become easier for doctors to prescribe it. Is it having its intended effect? Is it working? Like, if access was increasing at the same time when we also had, drug overdoses spiking during the pandemic, then kind of what's the relationship between these things?
Yeah, it's a really good question. And I will say, earlier in the epidemic, when we were still dealing with pain pills and then we were dealing with heroin, researchers I've talked to have said that was really the crucial period of time when expanding access to Suboxone and methadone and buprenorphine would have made such a difference, and then heroin turned to fentanyl. And throughout this time period, and still to this day, there are significant issues getting access to these medications. There are lots of prescribers who just are not willing to provide it. They don't want to treat addicted patients. And even though more people have access to these medications than ever before, there's still these barriers that prevent people from accessing care quickly. And that in the interim time between people wanting treatment and actually getting access to treatment, you can easily overdose.
Let's bring a caller in here. Let's go to Chris in San Francisco. Welcome, Chris.
Hi. I want to confirm what she described as the need for ongoing treatment. Well, I worked, I'm a psychologist. I worked in a residential treatment program for 5 years. I've done 2 formal postdocs in substance use disorder treatment. And there are people who are going to need support, ongoing, a higher level of care for life. What we say in treatment is, when is recovery over? When is recovery done? When are we done in recovery? Never. Recovery is for life, literally.
It's so tough. Thank you so much, Chris.
Yeah, thank you.
I mean, just taking a step back as like a society, if let's just say that's right, that like for a lot of people, they're going to be in recovery for life. What would the sort of optimal approach be to this? Like not what we have, but what maybe if you could just design it and dream, like this is what we would do if we actually wanted to help people who are very deep in addiction to recover and get on their feet for a very, for life.
Yeah, I mean, there's so many things we could do. I think making it easier to access treatment, particularly addiction treatment medications, is really crucial because these medications reduce deaths by more than 50% in some cases. So that alone, I think, would save a lot of lives. And then researchers I've talked to have also pointed out that treatment duration could get better. This 30-day treatment program model just really isn't working. And then I think this is something we've been talking about, this recovery capital question. It's a kind of broader question of what people actually need in order to recover. And I think what happens after treatment is sometimes more important than the treatment itself. And and there are some, there's some programs and states that are increasing access to the ongoing support that Chris mentioned, for example. They're funding peer navigators, peer coaches who can continue along with someone who's struggling with addiction and provide them with that support if they're having trouble finding it. And then I think treatment programs themselves could do a lot to help reduce the barriers that exist for people once they leave treatment. If they have a criminal record that bars them from accessing jobs, or I've talked with some people who are on Suboxone and find themselves barred from certain jobs just because of the discrimination against people with this who are taking this medication. I think reducing those barriers for people and helping people accrue recovery capital would really help people sustain their long-term recovery.
One of the difficult things that you get into in the book is the relationship between treatment and addiction and mothers and their children. I think it's not difficult to see why people working for Child Protective Services might see someone who's using drugs very intensively and say, your kid should not be with you. You're not a safe parent. You're not providing a safe home. One of the things you suggest in the book is that recovery addiction services should allow more women with children in, right? Do we have any examples of that working or where that has been able to help people?
I mean, hearing you talk about this, I think a lot about April Lee, who is someone that I follow in my book. And she, she witnessed her own mother struggle with crack cocaine addiction and kind of how the local law enforcement treated her predominantly Black community at that time. And for her mother in the 1980s, there was really no treatment available for her. And she was a single mother of 9 children. So when she wanted to stop using, the only option available to her was to take all of her kids to the homeless shelter. During that time period, there was a lot of awareness. There was a lot of concern about the lack of treatment for mothers. There have been decades of studies showing that women fare better in treatment when they're allowed to remain with their children. And that produces better outcomes for those kids, too, when they're allowed to.
That was my question. Is it better out for the kids, too?
Yeah. I mean, kids want to be with their parents, especially, parents who are well and who are stable and able to take care of them. So there's a huge body of research that shows that that families fare better when they're able to remain together and when a parent is able to obtain treatment. And this was such a concern actually during the crack cocaine epidemic, surprisingly, that federal lawmakers, really tried to push states to spend more money on treatment for women. And states, of course, did expand options a little bit, but not by much. And then this has continued to be a huge issue during the opioid epidemic. I mean, so many children have been removed from their families due to substance use over these many years of the epidemic. And still, I was looking through the numbers and to try to determine how many options there are out there for mothers. And over the course of the opioid epidemic, the number of treatment programs that allow women to bring their children or that provide childcare have dropped dramatically. I mean, in 2023, and these numbers have probably gone down even further at this point, but in 2023, only 2.5% of facilities nationwide allow parents to bring their children with them, and only 4.5% provide childcare. So this kind of places mothers in like almost an impossible position. They need to take care of, they want to take care of their children. They need to take care of their children, but they can't take a break from their children if their children are, if they're the only source of support for their children, they can't take a break from their children to go to treatment, So it really puts a lot of women in this huge, huge bind. And I think this is even all the more dire because while overdose death rates overall have been declining the past couple of years, the maternal overdose death rate has been skyrocketing. And so mothers are literally dying because they lack treatment.
Let's bring in Bill in Menlo Park. Welcome, Bill.
Thank you. Can you hear me all right?
Yeah, sure can. Go ahead.
So in our experience, taking off from the last caller, the 30-day programs just are not long enough and there's no follow-on support. What has worked, what we've seen is programs that are 4 or 5 months. There's a terrific one in Southern California, and that's followed by the addicted person staying connected to a sober community for many years after. So it's this long-term process of recovery. The 30-day programs, it's just not enough support. And what really the key is after the program that there is a sober community that provides discipline and structure for all the members and helps them stay sober for the long term.
Yeah. Absolutely. Hey, appreciate that, Bill. Thanks for sharing your experience. There are complexities, though, right, to some of these sober living situations, right? One of the things you document, and I'm not saying this happened in Bill's case, or not Bill himself, but people Bill knows. These sober living houses can also have an exploitative edge as well, right?
Yeah. I mean, it's been a source of a lot of concern in California that sober living homes are pretty much devoid of oversight. I mean, there's no regulations over them at the state level, and there's no place to really file complaints about them. And I think what's happened now, too, in the treatment industry is that a lot of treatment programs are, opening up their own sober living homes. And so these are people who, patients go to live in these sober living homes, and then they go to that program's outpatient program, intensive outpatient program. And if the program doesn't really have their best interests at heart, it's a situation where they're not empowered to live brand new sober lives. They're kind of under control of this treatment program that may be using them for profit. And so I think sober living programs really are so crucial for people who are new to recovery. And it's especially important for people who are living there, yes, to have accountability, but also to have a sense of ownership over this new phase of life that they're embarking on. And oftentimes what we see is treatment programs using them as a way to escape oversight.
A few listener comments here. Christina writes, the way the speaker describes Suboxone as hitting the same receptors as opioids without the high sounds a lot like the way Ozempic and Wegovy work in relation to food cravings, which is now pervasive and widely accepted in our country. Just saying. Another
interesting.
Another listener writes, I'm the mom of a heroin addict, and I put my son in jail after he pawned off family heirlooms. Before that, he graduated from Pomona College. He's now 30 years clean as a successful person, but life is not easy when you have a record and many jobs are not available.
So true.
I mean, it's so tough. We're talking about America's drug treatment systems and the rehab and addiction recovery industry with Shoshana Walter, author of Rehab, an American Scandal. She's now an investigative reporter for the Marshall Project. We, of course, do want to hear from you if you've had experience with the rehab industry as a patient or as a provider. What do you think the industry is doing right? What do you think it's getting wrong? You can give us a call. The number is 866-733-6786. That's 866-733-6786. You can email us your comments and your questions to forum@kqed.org. You can find us on social media, Blue Sky, Instagram, etc. We're KQED Forum. And, of course, there's the Discord as well. Another comment as we go into the break here. Alex writes, I lived in Boston from 2017 to 2019 along Massachusetts Avenue by Boston Medical Center. This stretch was known colloquially as Methadone Mile. I volunteered at the Boston Healthcare for the Homeless program and worked with people that were actively in treatment with Suboxone or methadone. Even Boston, with its panoply of some of the world's most top-tier institutions and facilities, seemed to struggle. What's the greatest impediment for making a broad, acute impact on the population? We'll be back with more on that, Alex. I'm Alexis Madrigal. Stay tuned. Welcome back to Forum. Alexis Madrigal here. We're talking about America's drug treatment systems, rehab, and addiction recovery industry with Shoshana Walter, author of Rehab, an American Scandal. Right before the break, listener Alex asked, what's the greatest impediment for making a broad, acute impact on the population? And I was just thinking, is it basically that in this country we kind of half-ass it when it comes to actually doing the evidence-based kind of harm reduction stuff? We kind of want to do that because it sounds good politically. On the other hand, we've kind of put this in the hands of like profit-making entities. We've sort of built this sort of strange Frankenstein of a system.
Yeah, I think that these issues with rehab speak to the limitations of our healthcare system. Treatment alone, I think the fact is that treatment alone is often not enough. It's these other facets that are really, really important. Part of my reporting process for the book that actually didn't make it into the book was I shadowed providers at the Bridge Clinic at Highland Hospital in Oakland. Mm-hmm. And so I got to sit in with patients and follow some of the patients who go there. And a lot of those patients are unhoused. I was surprised at how many of them made the trek from where they were sleeping on the street all the way to Highland Hospital. There was one guy I remember, he would pick flowers along the way from people's front yards and then bring them to the receptionist at the Bridge Clinic. And, he was in his 60s and had been in his addiction for decades. And what motivated him to start taking Suboxone was he realized that he had reached the age when his own dad had passed away from his addiction. And the problem, so there were tons of people in this clinic, a very low barrier entry clinic, that were on these medications and sober, sometimes not sober, sometimes succeeding in their sobriety. But these other aspects that they needed to really fully recover and move on with their lives and make a change were unattainable. There was the social worker at the clinic that was trying to get people into housing programs or, ongoing supports. And it's just a huge challenge because there's not enough.
What do you think? One of the things that we hear on the show a lot from listeners is that, San Francisco has tried harm reduction and it has failed. What do you think?
I haven't done too much reporting in San Francisco on this. The bulk of my reporting really took place during the COVID-19 pandemic. Mm-hmm. So that kind of limited my ability to really go deep locally. Mm-hmm. But I think there's been a lot of great reporting. The San Francisco Chronicle has done great reporting on this. The Atlantic just came out with a podcast about San Francisco. Mm-hmm. So I can't speak to the specific challenges that San Francisco faces. But I think that this resource challenge is a big one across the United States. Healthcare providers are that, first of all, a lot of healthcare providers still aren't providing addiction treatment. That's still a huge, huge problem. And then the ones that do, the ones that are committed, that are really trying to help people, they find that they can't do it all. They can't do it all.
Let's bring in Shauna in San Francisco.
Good morning.
Yeah, go ahead.
Sorry, can you?
Yeah.
Sorry. So quick 2 comments. One, I used to work in the General Assistance Building as a psychologist, and I used to also work at SF General with UCSF. And both my work is around substance and unhoused and mom's recovery from substance use. And I would say as far as like the resources in the city, they're very limited, particularly for moms in recovery. When we used to have moms deliver their babies and stay with their babies, because we're one of the only counties that do that, there's maybe 3 or only 4 places that we could really send them to. But even then, it's so impacted that it was hard to find the right sources for them.
Yeah.
And there's other counties, like we got moms from like Santa Cruz County or maybe over in Oakland, because they just don't have the services or the policies laid out. And I just want to say, like, everything you're saying is so spot on. That, like, just as a provider who's trying to do the work but also find collaborations, like, that is probably like the hardest thing to do. Is like, we might be able to do it, but when we're looking for the support, there's few to none or no space. So just wanted to make that comment.
Hey, thank you, Shauna. I really appreciate that. Experience with the system. Kate writes in to say, I'm curious if your guest views or approaches the topic of addiction differently based on the substance. After losing my brother in 2019 to a fentanyl overdose, I immersed myself in learning all I could about opioids and the crisis that was unfolding. I gathered that an opioid addiction is completely different from alcohol or other drug addictions and requires a very different recovery response approach, specifically the approach by friends and family to help someone with opioid addiction. Do you think the broad, quote, addiction category is flawed?
Oh my gosh, I love that question, and I don't know if I feel equipped to fully answer it, but I do think that that particularly with opioid addiction, addiction treatment medications are really important, especially with fentanyl. And I'm so sorry to hear about your brother. Fentanyl can be so deadly, especially after these 30-day treatment programs where you suddenly develop this abstinence and your tolerance goes down. It can be very dangerous to enter that kind of program and then come out of it and use again. And so these treatment medications are really crucial because they prevent people from dying. And there's perhaps not as great of a risk of overdose deaths with other substances. But I think that among researchers who study addiction, there's this kind of consensus that there's a real need for medications to assist people with recovery from other substances as well.
Meth in particular, right? I mean, that's what I've really heard is that, Suboxone could at least theoretically help someone with their addiction. If you're addicted to meth, it's like, sorry.
Yeah.
You just have to muscle through.
Yeah.
Johnny writes, why isn't personal responsibility the solution? Because whatever the good-hearted people are doing is not working at all, and it could be argued that the problem is getting worse.
I mean, I think personal responsibility is part of the solution. When it comes to recovering from addiction, the sense of self-efficacy, that you are in control of your life, that you can make changes in your life, is super important. But also, if you don't have the capacity to do that and you need help, that's important too.
Let's bring in Michael in Vallejo. Welcome.
Hello. Thank you. Thank you for having me on, and thank you for the show. So my question or comment, I have 17 and a half years clean and sober, and that happened because thank you. I went through a long-term program. Now, this was the second time I went through a long-term program. The first time I went through was in 2001, and I didn't follow instructions. It was a 6-month program, and I didn't listen to the instructions they gave about building what I just heard was recovery capital. The second time I went through a program was in 2007 in San Rafael in a program called Centerpoint. And it was a 6-month program, which then provided transitional living and continuing care. I went to groups as I was building up my recovery capital at the end. And I continued into aftercare while I was building up that support network. Afterwards, I joined and started working in recovery. And I've been working in recovery for 17 and a half years. And what I've noticed over the years is insurance companies, both private and Medi-Cal, are shortening the time that they're giving for a person to recover, which the science says that the longer a person is engaged in the treatment and recovery process, the better their chances. Yet I see insurance companies providing less funding, which seems to be inhibiting people in recovery. Is there a way that we can write laws that stop insurance companies from going against what's already proven in science to work?
Yeah. Thanks for that, Michael. Appreciate you sharing your
that's
experience
great.
with us. Thank you.
Thank you. Yeah, I mean, I absolutely. I think that there are even some bills on the table in California right now that kind of address these insurance barriers and insurance companies prematurely cutting off treatment. And if this is something you're really concerned about, I really encourage you to write your lawmakers about it.
Let's bring in Phil in Burlingame. Welcome, Phil.
Hi. I just want to make a small point, which is, when we think about, I grew up in South Florida and have seen a lot of addiction and, our friends and family. And we can't really talk about drug addiction as though it's like a standalone thing. It's a symptom. It's not the disease, really. I mean, the symptom is often childhood child abuse or dysfunction. It's a mask. It's a self-medication for some other things. So the idea of a 30-day program, getting somebody's head straight, even on the smaller level, are you addicted to chocolate? I mean, we all have addictions. There's this regulatory issue. It's not just about, drug treatment. That's my small point.
Yeah, appreciate that, Phil.
Yeah, thank you so much. Yeah, I think there's a theme that we're hearing, and it's spot on that this is a long-term process. And, most people who recover, who've gone through treatment, have gone through treatment 3 or 4 times on average. More than 10% of people have gone through treatment 6 or more times before they fully recover. And I think that's a testament to some of the problems we've been describing in the treatment system, but it's also a testament to how difficult it is to recover from addiction and how it's a long-term process of change for a lot of people.
A couple of different experiences coming in from listeners as well. Rosa writes, our experience with addiction treatments has been very difficult. Our 21-year-old son died from an accidental overdose. I'm so sorry, Rosa. He spent the last 20 months of his life going through different addiction treatments, lasting no more than 2 weeks each time, and he had a concurrent condition, psychosis. He was almost 20 when we found out about his addiction, so we could not make him involuntarily commit to long-term treatment. From the very first time he came out of a psychiatric residence treatment, his drug use and psychosis worsened. He was not capable of taking care of himself or making rational decisions, yet he would be released to the streets time after time. Rosa brings up an incredibly, difficult point, and obviously has lost her son there. Terrible experience. This has been a really difficult topic, I feel like, in addiction treatment, of when and how should someone be involuntarily committed, right? Because there's there's a civil rights issue at play. And there's also the sense of how can someone just be left to die on the street,
Yeah.
When you talk to people, I know for this book you talk to hundreds of people who've gone through recovery and are associated with the system. What do they say about someone like Rosa's son? I mean,
Rosa, I'm so sorry to hear about what happened to your son, and it's definitely an experience I've heard about time and again. I think that there's among the researchers that I've talked to, there's not even a full consensus about the right approach. And I think that, this may feel really unsatisfying to hear. And it is unsatisfying for me to say, but, there's no magical cure for addiction. different things are going to work for different people. But I do think that, one of the things that Rosa mentioned, these short spurts of treatment, it becomes a revolving door, and that's clearly not working and doesn't work for most people. And you can see how tragic the consequences of that can be.
Yeah. And just worth remembering, because I do think it's one of the takeaways from your book, that there are people, for-profit treatment facilities, that are benefiting very directly from people going in and out of that door over and over.
Absolutely. I mean, yeah, especially, there are treatment programs that hire people to go out and find patients with the best, highest paying insurance policies. And, they're very eager to welcome those patients back after they relapse. It's part of the business model for a lot of these treatment programs, and it makes a lot of money.
Yeah. The other type of long-term treatment that we've discussed in this hour has been a lot of these kind of work programs. The other thing I wanted to make sure people take away from this book is how little time people get in actual therapy, group, individual, whatever the methodology is, right?
Yes.
If you're working, I think in the facility that you describe in a lot of detail in the book, they ran the numbers, and a lot of people working 60, even 70 hours a week.
Up
right?
to 80 hours per week, yeah.
Yeah.
Yeah, this program, when Chris Kuhn, this is the person that I followed in the book, entered that program, they told him that he would be working and living there for 2 years. He'd be able to save money. He would get counseling. He would get medical services. And then when he entered the program, he quickly learned that actually the vast majority of the program would be spent with him working, being contracted out, almost like a temporary labor force to different private companies.
Yeah.
And he worked up to 80 hours per week. He was paid with nothing but a pack of cigarettes per week. And he rarely had time for counseling. I mean, I talked to one of his counselors who had a huge number of people on her caseload. She was supposed to see him at least once a week. And she said that he was working so much, sometimes she would just go and visit him when he was in bed, say, "How are you doing?" And then he'd say, "Fine." And she'd count that as a counseling session. So, it was almost like the work was the treatment. But it had the opposite effect for Chris and many people who went there. Just made them feel exploited. It made them feel powerless. It made them feel like they had no time or energy to really explore any of those underlying reasons for their addictions, or really even envision, what else they could have in their futures aside from this.
I want to get to a couple of last listener experiences here. Jenny writes, "Hi. 12 days of inpatient rehab for marijuana addiction. Worked for my 20-year-old family member, but the facility declined to accept him for ongoing counseling support unless he completed their online daily group sessions. He had school and work and could not complete the online part. He relapsed 6 weeks later. I wish the rehab facility would accept people in their group without such requirements. I would have paid money. They told me it's just their rules." Kathleen writes, "I am a licensed clinical social worker who has worked for over 20 years in addiction medicine, and I'm concerned that you're not focusing on alcohol as well. It is a highly addictive drug that is embedded in our society. People need to understand how easy it is to abuse alcohol and then progress into addiction. It's also an epidemic. People die from alcohol abuse every day. Kaiser has a continuum of care for the disease of addiction, which is fairly comprehensive, but still needs more resources. I'm not aware of any other insurance company who provides this level of care." Anything to note about either of those things, Kai?
I mean, the book mostly focuses on, the policies that we've erected in response to the opioid epidemic. But I totally hear that. I think alcoholism is a major issue in this country. And certainly some of these changes to our addiction treatment system would benefit people who are struggling with alcoholism.
We have been talking about America's drug treatment systems and rehab and addiction recovery industries with Shoshana Walter, author of the enraging new book, Rehab, an American Scandal. She's an investigative reporter for the Marshall Project. Thank you so much for joining us.
Thank you so much for having me, Alexis.
Thank you. I'm Alexis Madrigal. Stay tuned for another hour of Forum Ahead with Mina Kim.